hand during the session today. So, Brittany, I'm going to turn it over to you.
Okay, thanks, Kim. Good morning, everyone. Today I'm going to be speaking on the peer review practices and quality reports to the medical staff. And while these two topics you generally are relatable and overlap with one another, for purposes of the presentation, I have separated them out to include their particular functions within our organizations. So you'll see how peer review practices and quality reports to the medical staff flow and connect between the two. Next slide. We'll start with peer review practices. And so the purpose of a peer review is to monitor and evaluate a practitioner's professional performance for all relevant competency using multiple sources and through an objective and evidence-based process. Our MedExec committee, which we commonly call MEC, is responsible for overseeing this process. And I've kind of broken it into three different components. The first is focused professional practice evaluation, or FPPE, ongoing professional practice evaluation, or OPPE, and then clinical management review. So we'll go through each of these components individually and define the who, what, when, and how of each. The first one is a focused professional practice evaluation, or FPPE. And this process is done to evaluate a practitioner for newly or initially requested privileges. Also, when current performance is not present for 4 cycles of OPPE. So they have low volume, all of a sudden they have a huge increase. You really want to check their performance for that increase in value to make sure that they align. And then also whenever issues affect the provision of safe, high quality patient care. This is required by the Joint Commission under the medical staff chapter. And I have that link here for you that you can, it'll take you straight to the frequently asked questions guide on understanding the requirements. Next slide. So the FPPE process. So this is for any and all providers. So the reviewer is assigned by our MedExec committee. Quality's role in this is to help facilitate the process and ensure its completion. So MedExec kind of says who they think needs to be doing the review. If there's no specialty in-house, we send this external, and we have a contract with a company that we can send off reviews to them to get a true specialty external peer review for that. FPP is conducted using 5 patient records. So you want to make sure to choose 5 cases as soon as the provider has privileges granted. Those cases should reflect exactly what the privileges were that were requested, but you also want to make sure it's comprehensive. So just because they've had one ER shift and you had a good range of things that occurred, if they've had a couple more shifts by the time you're actually doing a review, like look through those patients, make sure you get an admission, a transfer, a pediatric, a procedure. You really want to encompass a review based off of what's actually reflective of the privileges for that provider. There is criteria by which the reviewer uses. So criteria for review is based on medical knowledge, clinical judgment exhibited, appropriate management of the patient, documentation that reflects the care and management, compliance with, best practices, clinical protocols, guidelines, and then also perception. So professionalism, communication, things like that. Get a full view of that provider's handling of that case. Once FPPE is complete, we do present this to the MedExec committee, who then takes one of 3 actions. They can either continuation of privileges. Hey, we like these 5 cases. There's really isn't too much room for improvement. We feel confident in this provider's competency, so they can continue on. Or further FPPE needed. We really want to see a case on this, or we want to see more of this. Then we can keep that provider into FPPE and do a little bit more additional focus review. Or also, you can also limit privileges based on the opportunities identified. It is important to point out, especially if you're in a small organization like us, that finding a provider with a like specialty as the provider requesting privileges may be difficult. And so it is important to have a contact or contract with an external peer review company for those instances. So for instance, we do have a pulmonologist on staff. If there were another pulmonologist who was asking for privileges here, we could choose that pulmonologist on staff, or we could go external just because it's such a small pool. You want to make sure that you're getting the most thorough review. Next slide. Ongoing professional practice evaluation is the process whereby we continuously evaluate a practitioner's professional performance trends on an ongoing basis. And that's obviously to make sure that we have great quality of care and patient safety. Again, like the FPPE, I did link this here to the Joint Commission's website on the Frequently Asked Questions Guide to understanding these requirements. Next slide. So about OPPEs, so this process is for all individuals who's been credentialed and privileged. MedExec again oversees the OPPE. The difference here is that actually the quality department here at our hospital, we perform the data collection and the compilation of results and present this to MedExec. Obviously, through our presentation, we're commenting on trends, we're commenting on things that may be outside best practices, but MedExec is responsible for the overall process. It is completed to provide a continual review, and we look to see they're evaluated in terms of meeting acceptable performance targets in each areas of general competency, so quality, efficiency, safety of patient care. We conduct these every 6 months. The Joint Commission has recently extended this to be annual. However, we haven't made that change yet. We like the cadence by which we do these. It does give MedExec an opportunity to really see the difference from a 6 month to a 6 month. And so we haven't really pulled the trigger on extending this at this time, but just know that that is something that was extended this past year. So how this is done is that there's a lot of things by which we are looking into providers, but this is not an all-inclusive list either, but volumes, turnaround times, review of operative or clinical procedures, so like moderate sedation, rapid sequence intubations, blood utilization, mortality, pharmaceutical usage, CPOE, length of stay, requests for tests and procedures, whether or not they consult, who do they consult with, compliance with core measures and organizational goals, and then patient satisfaction and complaints and grievances. That goes into that perception category there. What do our patients feel about our providers? The OPPE results are presented to MedExec, at which point they recommend any of the following: no actions. Everything looks good for that provider. They can also send a letter to a practitioner who demonstrated areas below the performance target, or they can request a practitioner be placed back into FPPE for further review. Both FPPE and OPPE, I do want to make sure that that is part of the practitioner's file, and it is available to MedExec whenever their recredentialing comes up. Next slide. So the last component of the peer reviews I'll review is clinical management reviews. And, this is comprehensive. This is anything in between. We initiate clinical management reviews with the goals in mind to, quality of care. Are we following best practices and established standards? Patient safety. Are we learning from the actual events that occurred and also the near misses through a review? Clinical efficiency. These are a part of the reviews to ensure our organization is set up for success with adequate resources. Compliance with regulations. Are we following the CMS regs, the Joint Commission standards? Does our documentation reflect that? And then finally, it's all for clinical performance improvement, because based on these findings of the review, developing and implementing action plans to address identified gaps in care, enhance clinical outcomes, and improve overall patient experiences. So on the next slide, To us, clinical management reviews, they come in all shapes and sizes. They are also many reasons that could trigger a review. This list provided here is not an all-inclusive list, and we actually encourage reviews to occur for the goal of process improvement. So we want people to bring forward things like, hey, I don't know about this, I don't know about that. Like, bring it forward. Let us look at it. Let us see, how can we learn from it? Is there an opportunity? Is there not an opportunity? Maybe there's an opportunity to standardize something that we haven't been able to standardize. So there's always a focus on performance improvement when it comes to clinical management reviews. Once the clinical management review is conducted, those cases, provider specific cases, are forwarded to the medical director for the department involved. These cases may also require external review from a third party company. Let's say it was the medical director that we had this case on. Surely we need to be going to somebody outside of that. Cases deemed not justified. So maybe there was an opportunity. Maybe we didn't follow this this core measure bundle. Maybe we didn't follow this moderate sedation procedure. Those are all things that we review for, and we mark justified or not justified. If it's justified, we provide feedback to the provider and we go along. If it is not justified, then we notify our med exec and we send this to them for a review of the case and to make recommendations for next step. No matter what, any clinical management review, whether they're justified or not, are all part of OPPE data compilation. So I have pulled these as part of OPPE. So, but for the most part, by the time I get to MedExec or we get to OPPE, a lot of times they already know about it because it's a continual process of our OPPE to pull what it is we're reviewing on each provider. And then finally, and the second part of this peer review is the quality reports to medical staff. So we do a lot of reviews with our MedExec committee. So moving on to quality reports for medical staff, these meetings are hosted by our MedExec committee quarterly. MedExec provides a quality report that summarizes all the key quality topics for the time period. And this report serves to keep all of our medical staff up to date on quality indicators being monitored, addressed, trended, and any action taken. And so I have included here some standard topics included in the list provided. What I hope for you to gain from this slide alone is that a lot of the work that happens on a weekly, on a monthly basis with our MedExec committee, with FPPEs and OPPEs and clinical management reviews, those all go back into an overall summarized quality report to our medical staff so that they also are up to date on what it is that we're monitoring, addressing, trending, and taking action on, with the goal, obviously, to have performance improvement at the end of the day, provide great care to our patients, great and safe care to our patients, and doing so by some of these topics I have listed below, just connecting the dots on what are some of those quality indicators that we feel as an organization are aligned to ensure that we provide the best care to our patients. So with that kind of completes my presentation portion on the topic. It was jam-packed, I know, so please feel free. I think my email is on the front slide. If you have any additional questions outside of, what this is today, I'll, definitely would respond back in an email to help share our practices more with all of you.
So thank you so much, Brittany. I saw there's a question in the chat too. I think this is such a big topic, and it's really kind of part of it's dependent on the size of your organization too. So in a critical access hospital, peer review is going to be done all as one group, through MedExec. And so you'll have, one set of indicators, right? If you are in a much larger hospital, it has separate medical staff departments with multiple physicians within each department, you might have separate peer review committees for each one of them and different peer review indicators for those too. And so this is one of those ones where no matter the size of your hospital, though, this is such a critical piece of the hospital quality director role, because the medical staff is the organized medical staff is, officially what they're called. They are a self-governed group, whether or not they are employed by the hospital. And we have to make that connection between the organized medical staff and the hospital's role in assuring that safe care is being provided. And it's that quality director role that's the middle person there. As you heard Brittany go through all of these, where we're reviewing, we're doing these things, so then we're bringing them to MEC or bringing them to the medical executive committee to review. And without that, there's no checks and balances. So it's a great, honestly, it really is a great system. There are lots of ways to do it. Some organizations, even in large organizations, have just one peer review committee that's made up of several different physician specialty types. And others keep it within their own department. There's no wrong way to do it. I think the approach that takes this OPPE, FPPE, that's really looking at trends and then also looking at a couple of focus areas is really critical to ensuring that the hospital is providing the best care possible. The other key thing that I think, Brittany, how often do you hear from folks? I don't, the culture in each hospital is a little different. And I've been in some hospitals where the culture was that if cases were brought for peer review, physicians were kind of on edge, and it felt, and those were in the olden days, it could feel a little punitive. It sounds like from yours that is not the case. And I'm so thrilled, because this is just like everything else we do in quality improvement. It's a learning opportunity. It's not an opportunity to point fingers at someone. It's, oh wow, what can we learn from this? So
Yeah, that's definitely, I would say, has been a change, over the years, is that yes, it was viewed very punitive. It's like, what did you do wrong? Where's the fault? Where's the blame? Because we've basically opened this up to be what it is, process improvement, performance improvement. There's cases that head to peer review that might not even involve the provider. There's multiple reasons why we do it. And with the goal is it to always, where's the opportunity, where's the improvement lie? Understandably, there are going to be situations where it just is what it is.
Right.
But that's where your just culture comes in. We have the algorithms by which we follow, and it's based on intent of the individual. And so if disciplinary action needs to be taken off of a case, depending on what the results may be, there's still a roadmap for that too.
Yes.
And no matter what, it always begins with a peer review or a clinical management review.
Exactly. Brittany, I also have a question. While people think about any questions you have, feel free to use the raise hand button and then come off mute or put it into the chat box. When your department is performing the initial review of cases, do you have a set of guidelines for, say, mortality review? Not every single mortality needs to go to peer review, right? But some organizations do just review all of them. Others have a kind of an algorithm that they walk through to see if it needs to go through. How does that work in your organization?
So specific to mortality review, obviously we categorize, those deaths. So not everything's going to our mortality provider, the mortality provider to review. Category 1 are things that's like, these are end stage patients, terminal conditions, hospice. These are understandable, clear, just process of the disease that caused the death. Category 2, these are deaths that occur to a possible complicating factor. The category 3s are unexpected deaths. We send everything forward, unexpected deaths. And there are criteria to even that on what we would call an unexpected death, because surely some things could be due to complicating factors, but basis of what we call an unexpected death, those are the ones who would go for a peer review.
Perfect. I see we have a question. Holly, go ahead, unmute your line. I'd love to hear your question.
Good morning.
Hello.
This is a great topic. I love it, and always trying to improve on that. One of the things I was wondering about is how you do feedback to your physicians on your OPPE or peer review.
So on our med exec committee, our med exec committee is comprised of an ER provider, anesthesia provider, a surgery provider, family practice provider. So we are, generally pretty robust and have a lot of specialties on that. As far as the direct, okay, Dr. So-and-so from the ER, this is your OPPE, that doesn't happen. They know through medical staff reports that what we are reviewing, what's those quality indicators that we're looking for. But unless there is something that MedExec deems as, maybe they were outside of benchmarks on an item, or maybe, there was an issue with something, that's when MedExec would let that provider know. But an overall, like, hey, we did OPPE these last 6 months, you look great, continue on. We don't really provide that generalized feedback. It is going to be very specific to if something was identified through the OPPE process.
We have a question in here too from Denise. Brittany, are you able to share the algorithm or the policy that you use about mortality reviews that
Sure.
goes through how you categorize? Thank you. Thank you so much. Any other questions, folks? Okay. Chat here. Oh, this is a great question. Some of the APPs we are performing initial credentialing with have worked at very small organizations that may only have one additional provider. How do you manage the peer reference requirements when there are not enough staff to perform a reference within the time frame? Great question.
This is think where the external peer review comes in. I budget, I think I budget for about 5 external peer reviews a year, just because you're not really sure what's going to happen. Last year I only had to use it twice. The year before that I had to use it more times. So there are companies out there that do this. You could choose the specialty by which you want them. So if this was a pulmonologist case, you can choose a provider to review your case in pulmonology. You can also choose it if they had it available in the state by which you live. You could choose it to be specific to that degree as well. And so that's my advice, is like, over time, I'm not scared to send anything out for external. It will give you the most unbiased review of the case, because even internal, we have you have a medical director for each department, and then under them there are several providers. So so let's say for radiology, we have a medical director in radiology, but then there's a lot of radiologists who read our reviews. So like, if we really want to have an external review that we're really concerned about, the external is always going to provide the most unbiased. I think it's a good resource to have, and one that I firmly believe in. And like I said, don't be not scared to send off, for sure.
I agree. And then if the issue is more along the lines of initial credentialing, and that person comes from such a small organization,
I've done them as well. I've sent off, we've had a pain specialist. We've never had a pain specialist here at this hospital. And so like who I'm going to get to review this. And I've sent off the 5 cases that, that were chosen to an external review company to provide that feedback. And help MedExec make an informed decision on whether to continue the privileges.
Yes. Perfect. This is so great. There's also, let's see, we have another question, MEC versus peer review. Do most hospitals in your experience have both? I think it depends on the size of the hospital. What would you say, Brittany?
I think it depends on the size of the hospital. We basically treat our MEC like a peer review. Just of our size, it's a lot, it's more manageable that way.
Yeah, and I see larger organizations have separate peer review committees. They might just have one, or they might have one for each one of the departments too. So again, no wrong way to do it. It really is more dependent on size and bandwidth there for the hospital. There's another question. Is there any specific group you would recommend for external peer review organizations? Remember, this is not
Yeah,
we're
I
not
mean,
advertising them here, but
yeah,
there's lots of great ones out there.
the one
Go
that
ahead.
we've used in the past is called MCMC.
Great, great. All right. Well, I know we are getting pretty close to the end of our 30 minutes here too. And so as always, we do have a little homework assignment that is truly, no one's turning them in or doing anything like that. This is strictly for those who are new in this role to get familiar with what it is that we're talking about and understand what's happening specifically in your organization. And so the homework for this week is to go back and review your organization's peer review policy. There has to be a policy somewhere that talks about peer review and how it's managed in your organization, and then review the last 6 months of peer review minutes. So again, that might come from, that might be an MEC, that might be in separate peer review committee minutes, it might be in a separate medical staff department. So however your organization does it, go back and review them. And then based on your review, are all of the peer review indicators that are listed in your policy, are those being covered? Are those being reviewed? When was the last time that the medical staff department reviewed or updated the indicators that they're looking at? That's another thing that is a responsibility of the medical staff, is to determine what it is that they want to be reviewed. Now, the caveat to that is there are some requirements also that come from CMS, that come from your accrediting body, but also, the medical staff should be aware of those and reviewing them on a regular basis. And then, are there any other, based on what you're seeing in the minutes, or you're seeing based on your understanding of risk management issues that are coming up, are there any other potential peer review indicators that you might think about that could be added here too for, maybe the OPPE for the ongoing? Are there trends that you would like to see? And then can you find the evidence of the ongoing monitoring of any past peer review issues that have come up? Is your organization following the plan and continuing to manage that? So just a few things to start thinking about as you get more comfortable with peer review. Again, it is a big topic. It's a long learning curve. Do not ever be afraid to ask questions about